Today we've got chapter 13. This is going to be our final sort of lecture um, for our sports performance class. We will have another lesson tomorrow, obviously, but it won't be like a lecture or anything like that. It'll just be us getting together in person, get you a chance to kind of get your guys' feet wet on how to perform a lot of this SAQ stuff. We'll be going out to the park and running some cone drills and speed ladder stuff. We'll set up some really fun versions of things. For that, I really recommend. I'm going to maybe text people individually and see if we can get a head count for, getting the morning group together for that. If you can make it in the morning, like I said, kind of at the beginning of this mod, that's probably going to be pretty handy. The evening is obviously possible. It definitely is like much fuller. We don't have that problem at Sochi because we have the whole place to ourselves, but like at night it tends to be like, a lot of kids' soccer games and things like that. Today we're going to talk a little bit about injuries. So we're going to talk about like what specific injuries there are that are very common in the sporting world. It's probably going to be ankle injuries. We'll understand the mechanisms for how those injuries actually happened, what the risk factors are for people who it's like, if you have this trait, what type of injury does that usually result in? Like we know that knee valgus, which a lot of people have, and foot flattening, which a lot of people have, are things that often cause lateral ankle sprains, like I talked about. And then we're going to talk about how to incorporate exercises to sort of decrease this. So it'll kind of go like injury by injury. Like I like this PowerPoint. It's set up kind of similar to how the corrective exercise class actually works, but it'll basically be like, here's what the injury is. And in this class, in this book, it's very non-specific. So when I say like lateral ankle sprains or something like that, it'll never actually really get that specific about how to fix it, because we don't really get that specific about how to fix stuff like that. For the most part, we're pretty general about our exercise, but it's like, how do you fix it? Well, you do a lot of like mobility drills and a lot of core and a lot of balance. And so we'll kind of be looking at like the basic versions of things. But anyway, we'll talk about like what the injury is. We'll talk about like sort of what often causes it and sort of how we have a general approach to fixing it. So if you are looking for specifics today, that's not really what this lesson's about. It's really a little bit more about like the sort of global general versions of things. But if you guys have any questions, please, like, I'd love to answer them. That's something I like this PowerPoint, but I have had students, sometimes it's almost a little unsatisfying because it's like, I need more information. That's me. What do I do? If you have anything like that, please ask a question. Put the hand up and I'll answer it. So obviously injuries pretty problematic for, it says athletes here, but anybody. With an athlete, it's going to cost you the season, but obviously that's just going to be problems in your overall general life. So we're trying to avoid injuries as much as possible. People always ask, what the difference between like a personal trainer, corrective exercise specialist, and a physical therapist is. And it's like, physical therapist will fix you once you're broken. Personal trainers, physical therapists are all about the rehab. Personal trainers, we're all about the prehab, right? We want to look at like what's going on with your posture and causing, these common injuries and stuff. So we want to stop them in their tracks before they really become an injury. If you've got an ache and a pain, let's see if we can get that to go away before it turns into something severe. So obviously there's lots of factors that can result in injury, very, very common in the world of athletics. Because it's so common in the world of athletics, we need to be able to kind of look at what some of these risk factors are and determine them. And we want to come up with like a strategy for how to prevent them, right? We want to prevent injury. And, if we have an athlete who did get injured, we also want to talk about like how to recondition them afterwards. So we can sort of, be like, oh, well, you probably had it because of this. Let's get you back on the right track. Let's see if we can fix it. So First one we're going to look at here, we're going to talk about foot injuries. This is going to be things like you can see Achilles tendonitis, which is basically inflammation of the Achilles tendon, plantar fasciitis, which is inflammation of the plantar fascia, and then like metatarsal, like stress fractures. Those are very, very common as well. So when we're looking at like common foot injuries, so whenever you see an itis, guys, if you ever see tendonitis, or sometimes you'll see like apathy, whenever you see like pathy, that's just like someone who's got something wrong with, and then like whatever word was before it is describing where it's at. Like Achilles tendinopathy is a problem, like a condition in the Achilles tendon, right? There is a slight difference between tendonitis and tendinopathy that you'll sometimes hear people say, but I don't think it's necessarily like a rule as a distinction. They'll say like tendonitis is like temporary inflammation where you get like an ache or a pain for a few days, maybe it lasts a week or two. But if it's lasting like 6 weeks or longer, it's like, okay, well, now we call it Achilles tendinopathy. It's like apathies are like chronic, and itises are acute, I guess. I'm not sure I buy into that definition fully, but sometimes you'll hear people refer to it that way. But whenever you see like an itis, guys, I want you to think inflammation, okay? Because that's what that means. So if we're saying tendinitis, right, that's inflammation of a tendon. And then which tendon is it? Well, it's your Achilles tendon, right? So that's going to be sort of an ache and a pain in, where your soleus and your gastrocnemius come down, and they're grabbing your heel bone here, your calcaneus, and wrapping around, and then it actually becomes your plantar fascia, right? Like if we look at that, like this is going to kind of work its way around and become the plantar fascia, which we know is also like a very common, sports related foot injury. So plantar fasciitis is inflammation of the plantar fascia. It's all of this sort of webbing down here on the bottom of the foot. So what happens is like if this gets really tight and it actually rubs on the bone here, it very much like tightens up. So you've got like, all this fascia. This is your palmar fascia here in like your hands. Well, you've got your plantar fascia, which is basically the version of that that's on the bottom of your foot. So it's this webbing that can get really, 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 really tight. And so, you'll get aches and pains around this whole area. You'll often hear people describe plantar fasciitis and Achilles tendonitis. You'll hear people say, it's pain that they have, and then it's worse in the morning when they first take their first few steps, and then as they get going, it actually starts to feel a little bit better. It actually doesn't feel quite so burny. They'll describe it as like a stabbing pain near the heel sometimes if it's plantar fasciitis, and so they'll describe that. And then they'll say it goes away after they get up and moving. And that's like after they start moving around, it kind of loosens everything up. Blood flow, heat gets to the area. And so that actually causes it to kind of relax. That relaxation is really what we are trying to achieve. And then metatarsal stress fractures are another one. If the foot is very, very rigid while your client is trying to run or do physical activity, box jumps, whatever, usually we'll see stress fractures in the second or the fifth metatarsal. And again, just a review of anatomy here. If we're looking at sort of a review of your metatarsals, right? The way we kind of label out your hands and your feet, right? You've got like, we've got that mammal, arrangement. One bone, two bones, lots of bones, and then digits, right? And so your wrist is going to be like your carpals. Then you are going to have your metacarpals, which is making up your palm. And then you're going to have each of your individual digits. Those are your fingers. Same thing is true in your feet. You have your tarsals, which would be like your ankles and all these little like, kind of cuboid bones here. Then you have your metatarsals, which are all these right here, and then all the digits, which are going to be your toes. So generally, when we see a stress fracture, it's usually on the outside of the foot here, in one of this like the bridge of the foot in this direction, like the fifth metatarsal, or right in the center here where it's getting pinched between 1 and 3. But you can get a stress fracture anywhere, those are definitely just the most common. And again, if your foot's too rigid, that's usually where we'll kind of see that kind of thing. So when it comes to these types of injuries, when it comes to foot injuries, whether it's a plantar fasciitis, tendonitis, stress fracture. Honestly, the big thing that we're focusing on for injury prevention is proper range of motion of the foot and ankle complex. So we need proper extensibility of your calf muscles. Remember, if we look at like your calves, you've got dorsiflexion and plantar flexion. Dorsiflexion is basically the extension of the ankle, and plantar flexion is basically the flexion of the ankle. They get special names because of the angle of your foot and stuff, but we need to see proper dorsiflexion in that ankle. So a lot of times, I mean, you even saw when I pulled up like plantar fasciitis, you'll notice like, it's going to show a lot of pictures of like what the injury is, but look at how many, pieces of equipment. This is designed to pull you into, this is designed to pull you into dorsiflexion while you're sleeping and not allow you to kind of point your toes away while you're asleep. You can see here, same thing, that's pulling your toe up, all these like little pieces of equipment that are designed to like increase your dorsiflexion, right? And then also in the foot, you'll also see a lot of pictures here. You can see a lot of people working on the bridge where they are kind of beating up their plantar fascia at the bottom. That can hopefully result in a less rigid foot. But then also sometimes it'll be insoles that actually increase, how far your foot is actually flexing, right? They're looking for, foot flexion there. So that's, a lot of different takes on this to fix plantar fasciitis. It is a pain in the butt to fix. Any foot and ankle injury is honestly tends to be the hardest to fix, just because, you have to take time off in order to kind of give an injury time to fix. And it's like, how the heck do you take time off from your feet, So proper extensibility of the calf muscles is huge, and then proper strengthening of those calf muscles as well. It seems a little weird because we just talked about stretching them, but oftentimes it's just a lot of dysfunction. And so we need flexibility and we need strength there. Sometimes it's strengthening of the proper calf muscles though. Like if you have an overactive lateral calf and you have an underactive medial calf, well, if we stretch the lateral side and strengthen the medial side, that could have the positive effect that we're looking for. We also need to see proper strengthening of the anterior and posterior tibialis. That's the muscle on the front of your shin. Those muscles on the shin there where we do exercises such as like, controlled ankle rolls. I love this calf raise with like a little, squeezing on like a ball here. That's really good for your posterior tib. And then, obviously there's resisted dorsiflexion and resisted inversion. So you can see here, right, this resisted inversion is really good for your posterior tibialis. This version pulling this way, where you pull, the band pulls this way, you pull your toe this way. That's resisted dorsiflexion. Both of those are really, really good for strengthening the tibialis muscles. And here's the version how you can do it by yourself there. If you've got one of those bands, you can kind of wrap, you wrap it around this way. Now you have the ability to kind of invert and pull your toe back. So here we go, working on, anterior tib here. We got a posterior tib exercise over here. So, those are really, really big ones for strengthening the muscles that are often associated with foot and ankle problems. Also, toe flexion is actually a big one, strengthening toe flexors. So this one is a little bit can be sometimes challenging to want to work on because it does literally involve like pulling your toe into extension and then curling it under. And it's like, I'm going to do freaking exercise for my freaking toes. Really? Like, that's not going to burn very many calories. But honestly, guys, it's a big, this is something that maybe, yeah, you don't do it in the gym. You learn it with your trainer in the gym. And then, you get yourself at home and you do it as sort of your homework. But strengthening those toe flexors, if you have like plantar, metatarsal stress fractures, this is a huge type of exercise to really practice. And then there are towel scrunches. Literally doing something like this, you roll up a towel and then you unroll it with your foot. And that can be really good at strengthening as well. You literally, take a towel as it's stretched out and then you just kind of pull it towards you, you kind of roll it up and then you kind of push it back the other way. Both of those are really helpful for, bridge of the foot problems. Or even just like one of my favorite that's like a little bit more dynamic is like a towel like grab from the floor and then you lift it up and you hold it in your foot as you do like a little bit of a balance exercise. I will do that with my clients since it's a little bit more dynamic. If I've got a client coming back from an ankle injury, or if I've got a client with like plantar fasciitis or something, I will sometimes do that in the gym as sort of like my movement prep section. Is it in the book? No. But like it's a great like balance stabilization exercise because am I moving my balance leg? No. Great. Am I doing balance? Yes. All right. Balance movement that doesn't move my balance leg, balance stabilization. If I've got a client in stabilization, literally perfect. They pick it up, they hold it in their opposite foot, and then they're balancing on their other leg. I'll have them hold it, 15, 20 seconds, and then switch to the other side. So those are some really good like foot injury, or that's sort of a brief overview on foot injuries. Mo's going to go over this kind of stuff much more specifically with you guys, but today is a really good kind of taste of what it looks like to get into the world of corrective exercise. Looking at ankle injuries, the biggest one we're going to see is, the ankle sprains are definitely the most common sports injury. And then lateral ankle sprains are the most common ankle sprain. But when it comes to sports, ankle injuries is definitely the big thing that we are often going to see. And so, the big areas that we're going to generally see this are going to be, like I said, lateral ankle sprains, which are definitely going to be the most common. That is going to be an injury right here. You will either see a tear in this ligament right here, which is called your ATL ligament. Not to be confused with your ACL, but that's your anterior talocrural ligament attaching, this little area here. And then, and then this one here. This is actually, sorry, I have that messed up. This is your CL. This is your ATL. I just got lost. Here's your calcaneofibular ligament, which, this is your calcaneus. This is your fibula. That's the most common one. And then immediately, like the ATL, anterior talofibular ligament, that's also very common from your fibula here to the top of your talus. Talus is basically like your navigator for your entire ankle. You can see it here. It holds your tibia, onto your foot. So that's a big one. So those are really common. And what will often happen is you'll see someone, when you hear someone say, I rolled my ankle, they're talking about, if it resulted in like a tear, that's a sprained ankle. So whenever we say sprain, we're talking about, we talked about a pulled muscle or tendinitis. That's problem in a tendon. Remember, tendons attach muscles to bones. Sprains are where ligaments, which is attaching bone to bone, gets injured. And so, the two big ones that we're going to see, right? We'll see someone roll their ankle like this, and we'll see tears in either right back here, here, or here on those lateral sides. We will also sometimes see medial ankle sprain tears. This is pretty uncommon. You are not going to see this as often, but a medial ankle sprain tear is where somebody rolls their foot this way. So they'll actually go into excessive eversion. Doesn't happen all that often because honestly, like athletic movements don't occur that way very often. And also, you know, when we look at, woo, that's intense. That's a lateral sprain. Medial tears, which are on the inside section, right? Like right about here. They don't occur as often because you would have to flatten your foot, you know, your knee would have to cave inwards. And number one, your other leg is in the way. So that's going to kind of prevent you from moving that direction anyways. And number two, one of the reasons that we're about to get, when we get into the reasons of as to why these injuries happen, when you look at like excessive eversion, that's what often causes the lateral ankle sprain. So let's say somebody's got a posture where they are just naturally pronating the foot, right? They're everting, they're dorsiflexing, right? They're externally rotating. All this, their foot kind of just naturally, you know, they're flattening the foot, right? That classic problem we talk about in pronation distortion syndrome, right? Well, if you think about that, they're stretching, they're creating like hypermobility. They're creating like an overstretch on the medial side. So if they flatten in that direction, they're probably not going to experience a tear because those ligaments are going to be really, really flexible. And what's happening on this side? Well, they're tightening up the ligaments over here because now these ligaments are not sitting in a neutral position. They're sitting in a shortened position. They're getting used to being in that position. So then the first time somebody rolls their ankle like this, it results in a sprain, even though it should be able to move through that range of motion. So that's why lateral ankle sprains are so common, is because, well, friggin', you know, eversion is super common, right? Like we see people, our clients sit in pronation distortion syndrome, right? Like this is the very common posture we see people in. Like this is, you know, this is you know, not as flexible as it's supposed to be, right? We're seeing like this side result in like a friggin' sprain, and we're seeing the other side kind of result in you know, overstretch, right? So definitely not what we're looking for. And then there are also high ankle sprains, and high ankle sprains are arguably the most problematic. But that can also happen, and that's actually going to occur at, you know, way up here. Like I said, that's either going to be your ATL, or it could even be where your tibia is connected, or it can be in the ligaments that are actually attaching your fibula to your tibia. And so, you know, there's a lot of fascia that holds these two bones together. Yeah, you'll see it like way up here. You'll see like that's where you'll see like the bruising and stuff. And what can happen with that, and the reason this is so problematic, and this is like really bad. There you go. There's, oh, this is really, yeah, lateral, and then broken toes as well. And then there's probably a high sprain up there underneath the hand. So the reason this is so problematic, there it is. Freaking finally, I was looking for this. There is a lot of fascia that holds your fibula to your tibia, right? And there's all of this fascia that's holding those two bones. I mean, you know, we've kind of described it like you can see these two bones just kind of independently sit on the ankle, right? Look at how, really, I don't want to do that. Give me a different one. There we go. So look at right here, right? You can see your fibula, you can see your tibia. This sits on your talus, and then this kind of sits off, you know, this is that lateral malleolus. This is the knob on the side of your ankle that you're feeling. But like all of this sits on your foot, and this ATL ligament holds these two together at the bottom. Well, all of this fascia and this membrane here also holds these two bones together to keep them from sliding apart. You tear this ligament, it makes it easier for them to start sliding. You tear this ligament, or tear all this fascia, that also makes it easier. So it all starts to like kind of slide away. And now these two bones, which are meant to kind of sit next to each other, start separating. And so this is where like this type of ankle sprain, depending on how severe it is, often requires like surgery, and, you know, sort of a cleaning out of all that fascia. You'll also, you'll kind of get like a lot of problems and scar tissue in there. So they'll often have to go in there and kind of break up that scar tissue. I know some of you definitely are more familiar with this than others. Um, so let's look at it. Lateral ankle sprains. The mechanism, we kind of talked about it, right? That's excessive inversion of the foot. We see it in people who have excessive eversion in their posture. So our risk factors: poor balance, the shoes that people are wearing. If people are wearing really rigid shoes with like an elevated heel, if people are wearing elevated heels all the time, again, that's going to tighten up their calf muscles, right? And then if they have a history of like a prior sprain, this is a very high re-injury rate. If they've sprained this before, it's likely that they'll do it again. Medial ankle sprains, very much less common. The mechanism for that is excessive eversion, which, because so many people already have excessive eversion, they would need to sort of have a supinated posture pretty regularly, which we just don't see that very often. We don't see too many people with too much supination, but they're the people who are at risk of this. And then high ankle sprains. High ankle sprains usually happen in like the NFL. You'll see it happen because what'll happen is like someone's foot will get grabbed as they're trying to make a play. And so you'll see a sprain like that. It often involves external rotation while they are also like dorsiflexing, and then the foot is pinned in place. So they're basically like spinning and pulling it back. And that's what's popping, that ligament away and then separating some of that membrane that holds the two bones together. Also, you'll see it in military folks who are wearing like a really rigid boot, whose foot gets, stuck in something because that boot, and then like they twist and turn. That will also cause that problem. So you'll see it in rigid boots. You'll see it in sports that involve like really strong cuts while someone maybe pins their foot. Definitely not, what we're looking for. So how do we prevent it? We talked a lot about it. How do we fix this freaking problem? Well, one of the biggest things is proper dorsiflexion range of motion. That is going to honestly, that'll get you so far. So proper dorsiflexion range of motion, if we're talking about that, this is where sometimes there's pieces of equipment out there that you can, actually get and sort of practice with. You'll see, come on, internet, really? Huh. Really?
So, Brad, I got a quick question.
Yeah, what's up?
When I first joined back in 1994, they used to give us two sets of socks. So a white pair and a black pair, and we always wore the black pair over the white pair, because so you couldn't see the white in the uniform. But it also did it for like shin splints, would give you more cushion and support, because back then we were wearing boondocks before they went to the actual, the flight day boots that have steel toes and a little bit more. But does that really work? Because I used to wear that like all the time. Like no matter what, I always wore the two socks. Does that really help with support?
Oh man, that's a tough question, because you're kind of asking like, hey, do compression sleeves work, right? Because it's kind of the same idea. The science is kind of out on compression sleeves. Here's the thing about like, shin splints and stuff. It's coming from like excessive impact. Pounding that causes like inflammation. And so if it works, here's the thing, like we know like fixing range of motion is going to work. We know strengthening is going to work. If compression sleeves, you'll see people, athletes wear them and stuff, and people swear by them. It's kind of like KT tape. Some people have had really good results with KT tape as well. And other people like, just doesn't do anything. I think that it's one of those things that works, but doesn't necessarily work the way we think it does. Like it's one of those things that like it has some possible positive effects, but maybe not for the reasons that people sort of think. I think that if wearing two pairs of socks creates compression, I think that compression draws your attention to your lower leg more often. So then you are more conscious about like what you are doing. That's how I feel about KT tape. Like when you tape something up, you are then more conscious of how you are moving. When you're wearing a compression sleeve, you're more conscious about like what you're doing, and awareness and consciousness always improves athletic performance and reduces injury, you know?
Okay.
But I don't know that just like the compression would necessarily reduce your risk of you know, shin splints and stuff. Does that make sense?
Yeah, I know they went away from it, and it definitely changed.
Yeah.
There were
Yeah, but I
definitely more
mean,
people having them afterwards.
right. Yeah, but I don't know, you know, it's kind of like those elevation masks that I talked about. It's like, do they work? And it's like, it depends on what you mean by the work. It may make you better at cardio. It does not improve your red blood cell count, you know, like it's not actually elevation training, but it does improve mental toughness, which has some carryover. It has positive effects. So maybe you got me with a good one, Dalen. I don't have a straight answer for you.
Appreciate
um,
your info.
yeah, those are my favorite kind of questions because I'm like, oh no, we'll all have to try. But if you've got ankle problems, dorsiflexion, guys, improve your friggin' dorsiflexion. So we can see a million calf stretches here. This is kind of what I'm looking for. I'm just looking for one where someone's actually doing it. There we go. Sometimes you'll see these little boards you can buy. I don't think you necessarily need like a slant board to improve your dorsiflexion, but they can be. I mean, like if you've got one, yeah, go for it. But honestly, the same thing can kind of be achieved by, you know, putting your heel up on something. My favorite, honestly, stretch is actually just I really like this version here. I will do this version a lot. I feel like I do this version a lot because it's very convenient. It's actually not my favorite calf stretch. It's actually my least favorite calf stretch because you're kind of jamming everything down. But this version here, I really like where you just drive your heel into the floor, bring your knee way, way, way over past your toe. I know that is often a no-no in our industry. We're often telling people to not put their knees past their toe, but that's much more about like proper squat form than anything. This is a stretch. This is not going to put you in such a level of stress that you're going to get any aches and pains here. Really great for improving that dorsiflexion. And then even better than that version is doing that stretch while putting a band around your talus. So remember, your talus is this navigator bone right here, right? It is the beginning of your ankle, just below. Now this bone can get moved around a little bit if you've had like consistently tight muscles. It's kind of floating, you know, it's floating between all these other bones. So when you take a band and you actually like wrap it around the talus there and it pulls backwards, you are doing what's called distraction. You're distracting the bone. Distraction is where you are manually, like I'm distracting these two bones right here because I'm pinching them together. They're moving inside my body. I'm not doing enough to like create any pain or anything, but that's if you've ever had like an injury on the field and like the you know, doctor, whoever, like you know, medic comes over and like squeezes things first. And you're like, why are you squeezing? I sprained my ankle. They're checking to see if you have any fractures. Because if you distract a bone while someone's got like a fracture, you are going to feel it. So this distraction here is actually pulling the bone back into proper alignment while you then do that knee forward action. This is a fantastic soleus Achilles tendon stretch. Freaking love it. But maybe you need the gastrocnemius, right? Maybe you don't need it in the, maybe that's not where you need it. You know, maybe instead you need an upper calf stretch. Well, that's where our favorite becomes, you know, soleus stretch here, soleus stretch, looking for a freaking straight leg, friggin' stretch, please. God dang it. These are all soleus stretches. There's a really good one. The straight leg, there we go. Straight leg wall stretch, okay? This is also really good at improving that dorsiflexion. So you kind of need a combination, right? Soleus stretches are with a bent knee, gastrocnemius stretches are with a straight leg, and that is going to be very good for improving your dorsiflexion. Balance training is huge as well. We know that if we have proper balance, we're going to recruit the muscles in our legs. We're going to move the way we're supposed to. Again, kind of just bringing awareness to the body, which we just talked about is huge. And then strengthening your dorsiflexors, right? Strengthening your dorsiflexors and your inverters. Learning to pull those toes back towards us with that band, just like we talked about in the foot injuries, right? This is the same thing here. So again, I will do towel scrunches sometimes. I will do resisted dorsiflexion, resisted inversion, right? Both of those things with the bands, very, very helpful stuff. I know it's not the most interactive, fun stuff in the gym. It doesn't feel like a gym workout or anything, but like that's the kind of stuff that, prevents a lot of these injuries. So from there, we got knee injuries, moving up the leg, right? We're kind of away from the bottom. It's like, can you imagine if like we had one person who has all of these? It's a broken little body. So next one we got our knee injuries, right? Very commonly injured area. It's your knee is trapped between, it's trapped between two of the most mobile joints in your body, and it is the largest joint that you've got. In terms of like, look at how much surface area is here. That's a huge joint compared to the rest of the body. And it's trapped between your foot and ankle, which is then trapped, immediately like interacting with the ground, the most immobile thing in the universe. And then it's also, you travel up trapped between your hip joint, which is like the most powerful joint in your body, your hip joint's the most mobile, along with your ball and socket shoulder joint, but it's got the largest muscles attached to it. So this is a pretty easy place to tear. Most common are going to be general patellofemoral pain. That is basically going to be poor patellar tracking, where your actual like kneecap is not moving the way it's supposed to, so it starts grinding. It sits in this little groove that I'll show you here in just a second. But if this is tracking improperly, you'll get patellofemoral pain. And then we've got ACL tears. That's a really, really common one. Runner's knee, which is sort of, we know it as IT band syndrome. Meniscus tears, that's another really common one. And then we've got the other tears within the knee. We see PCL tears, LCL tears, MCL tears. Some are more common than others. But let's start with poor patellofemoral tracking. So patellofemoral pain is sort of general knee pain, right? Sometimes we'll describe it as like maybe like just an ache and a pain, or it'll feel like arthritis of the knee, even though arthritis would be specifically if you're missing like connective tissue. But what is happening, let's see if I can find a poor patellar tracking GIF. Let's see if I can find a GIF of this. So here's how your kneecap actually works. You'll notice as this knee kind of moves through a range of motion, right? Look at how the kneecap is meant to actually slide like this. Now let's look at that groove from the front. You'll sometimes see glides that are moving in a direction we don't necessarily want it to move in. So I'm going to kind of, you can see if we have a weak VMO, yeah, that's a big one, right? And we have a really tight, oh, lame. That's so weird. The preview, it looks nothing like the freaking thing I clicked. So if you have a weak VMO, that's a vastus medialis oblique. That's one of your quadriceps. That's the inner quad muscle, the teardrop quad muscle on your medial side. Yeah, I'm never going to get a GIF of this. What am I doing? Let's go to YouTube. Poor patellar tracking. Can't help but think that this is going to be a PowerPoint, but it's only 2 minutes long, so how hard could it be?
This is the Nordic Track Rower 900. There's
Yeah.
different options and places that you can row. You can basically row.
Hush.
Ended or
Yeah, no, it's a PowerPoint. All right, that's not helpful either. God. Internet, you were Internet's letting me down. Here we go. All right. So here is your kneecap, right? That's your patella. And then here's that weak VMO muscle. Now this is the top where we're looking down the thigh here, right? And what's going to happen here is we're going to see it's supposed to glide up this groove. It's supposed to move up this, but if it tilts or if it laterally moves to the side and glides this way, that's not great, right? It's supposed to move straight up and down. But if you've got a tight quad muscle on this side, that's your vastus lateralis, and you get a weak VMO, well, what happens? It gets pulled to the side like this, right? And now it can't glide up the way that it's supposed to. We see, you know, a bad unequal amount of force in here, right? And so instead of sliding up the femur the way it's supposed to, instead we feel an ache or a pain associated with that rubbing sensation. So oftentimes you'll see people give a knee brace that'll kind of help with that. But the problem with braces that I'm not a huge fan of, I mean, if you want to wear this during like certain amounts of physical activity, great. But like my problem with like bracing something and just wearing a brace every day is you're not really addressing the problem. You are keeping the pain from going away, you know, but you're not necessarily like addressing, you know, you have a problem with stability, and now you are putting a thing around the area, which is preventing you from training for stability. So there we go. That's actually kind of cool too. You can see this person here is actually kind of manually moving the kneecap around, right? So you can see like it's laterally moving here, side to side, just like that, right? Instead of the way it's supposed to move up the femur, right? Now let's look at like, actually, there it is. Yeah, in the anatomy. So let's look at what's supposed to happen. When we look at the knee here, right, as it moves through a range of motion, this is a view from the side, it moves like this, right? This is your knee joint as it moves through a range of motion. So it is actually sliding up and down the femur, right? And then you can also kind of see, remember we talked about the difference between like rolling action and gliding action? There's the rolling action. There's the sliding action, gliding action at the end there. See from the side, right? So this is what's supposed to happen. Looks like a freaking spaceship like docking in a sci-fi movie, right? Like it's supposed to stay in the groove, right? But patellofemoral pain will come from abnormal tracking. It'll either move, generally, I will say, the most common is where it gets pulled laterally. A lot of people have a really tight vastus lateralis because working with the biceps femoris is working with the TFL. So when you see, again, knee valgus, you see somebody who's doing that pronation distortion syndrome, which we view it by seeing the knees caving in. We call that knee valgus. Generally, we will see that cause the patella to slide laterally because the vastus lateralis, the biceps femoris, all the lateral muscles here are causing this internal rotation, and then they're attached to the, you know, they're pulling the patella to the side, this way towards the outside. So that'll cause like an ache and a pain. You'll get like it'll feel like a burning sensation on the outside of your kneecap. But I mean, honestly, you can have poor patellar tracking in any direction. If you had a client who, you know, has excessive knee varus, knee caving out, bow-legged syndrome, pretty uncommon. You don't see this in too many people, but it can absolutely happen. It'll be out there, you know. And if you get a client with this, well, then their patella is going to track too far medially. And we got the very rare problem of having an overly developed VMO, which we don't see all that often. But so that's patellofemoral pain. Any questions on that? I feel like I've talked this one to death, but I may have overdone it. Anybody unclear? Did I go too far and make it unclear?
No, you good.
Okay. So knee valgus, big risk factor, decreased knee strength, decreased hip strength, increased Q angle. Again, increased Q angle literally means knee valgus. And then foot pronation, right? All of those things are going to cause this to track abnormally. All right, let's move on to ACL tears. So before we do this, let's look at knee ligaments really quick. So you got 4 main ligaments in your knee, okay? You have got your ACL, which is this one right here. That's the anterior cruciate ligament. You're going to get your PCL. That's your posterior cruciate ligament. So word anatomy, anterior, it's in the front, posterior is in the back. So the anterior cruciate ligament, if these are making an X, it's the one, if you guys are looking at it, this is the anterior one, and then this hand back here is the posterior one, right? Well, ACL is in the front, PCL is in the back, okay? So there's the anterior, posterior side of things. Cruciate, the C, actually stands for to make a cross. Like think about like, you know, to crucify someone, right? They put them up on a cross. These ligaments are crossing over each other. That's why it's the anterior cruciate and the posterior cruciate, and then the L is the ligaments. So they make an X like this, and they create stability within the knee with that X. Then you've got your LCL, that's your lateral collateral ligament, and your MCL, that is your medial collateral ligament. So LCL is on the lateral side. You can see there's our fibula down here, right? So it attaches my femur to my fibula, and my MCL attaches my femur to my tibia, right? And so these are creating stability on the outside of the knee, and then the ACL and the PCL are creating stability inside the knee. So you got the cross, and you got some on the outside. So those are the ligaments of the knee that are creating all that stability. Guess what? If you are planting and you are cutting, and generally that's a cut to the outside that most people make, what'll end up happening is you will be twisting your knee this way, which is now pulling your ACL apart in this direction. If it doesn't have that proper mobility, when it gets pulled apart, it's going to let go. That's going to create that tear. Now, it can happen in the PCL ligament as well, but it's way more rare. This ligament's the PCL is also a little thicker, which is why it's a little bit more able to handle the stress. But also, like the PCL, that's not a direction that people make a lot of strong cuts into because your other knee's in the way. Like if you're trying to move it this way, you're gonna slam your kneecaps together before you tear your PCL. Generally, the only way you're gonna tear a PCL is if like you are hyperextending the leg while you are also trying to do a cut. Ace and it has to be in a direction that most people generally don't try to make an athletic move. ACL tears, though, very common in the world of sports because a lot of times we have these like really strong cuts to the outside. You'll be sprinting and then boom, you make a cut to the outside there, and you'll drive your knee and your foot into the ground really hard to make this really big, powerful cut, and that's where you see it, right? Or sometimes you will see it during a straight knee landing. Sometimes people will go up for like a big jump in like basketball or something, and then they'll land with like a hyperextension there. And then as they do that, honestly, hyperextension would be okay if it wasn't for the fact that like when it happens, there's probably like you're not just jumping straight up and coming straight down. If you were stacked perfectly, you actually might walk out of it okay. But generally, it's sports, right? So you're probably twisting a little bit to one side or the other, maybe moving laterally a little bit. So when you like land hyperextended, you're not able to kind of deal with those forces, and then you twist and tear that ACL. So our big risk factors, what causes ACL injuries? Knee valgus, that's a big one, right? Again, the knees caving in is going to cause this. So both of these have the same sort of problem here. Excessive leg rotation. If you do notice that somebody has like a little bit too much transverse movement there, we like transverse mobility, but be careful if it's like, you see it without the stability, without strength. Like you got the mobility without stability, that could also cause a problem. Decreased knee flexion. If you notice that somebody has really tight quadriceps muscles, that can cause this. Like if they can't perform like knee flexion, if they can't bring their heel to their butt, that's not a very good sign. And this is a weird one, but this is a big one. Hormonal problems can actually cause this. We generally see this in female athletes who might be struggling with like disordered eating. The female athlete triad, which is basically like eating disorder, which causes like a loss of like menstruation, will cause like an alteration in hormones. Those alterations in hormones can actually, eat away at your connective tissue. Basically, your body is starting to look for as many proteins as possible in order to convert those proteins into hormones, and it will eat it from your connective tissues and muscles. Very common in the world of athletics. Actually, we won't be talking about that in this course, but it'll come up next mod. So be cautious with that for sure. Patellofemoral pain, right? We talked about that one. Oh, I forgot the PowerPoint actually doesn't have it in here. You will also learn about runner's knee and meniscus tears. I'm going to talk about this now because you're going to see it with Mo anyways, so I want to mention it. Runner's knee, which is just an ache or pain, sometimes can be described as like, again, here's poor patellar tracking, the kneecap's out of alignment, but you will also sometimes see it on the outside of the knee here, where you will get IT band syndrome. So IT band syndrome, runner's knee / runner's hip. Oh, that's right. Maybe it actually comes up in the hip section. Nope. Okay. So runner's knee / runner's hip. You will get a rubbing, burning, achy sensation on the outside of the hip here, or a rubbing, burning, achy sensation on the outside of the knee there. If your IT band gets really tight, your IT band has to wrap around this lateral condyle here. And so it'll actually rub on the outside portion of the femur there. That rubbing sensation can cause like swelling and pain and just inflammation. And the same thing can happen in the hip because you've got the greater trochanter at the top of your hip here. So it'll rub on the outside here, or it'll rub on the outside here. If that muscle gets overly tight. So we need TFL mobility, tensor fascial latae mobility, and IT band mobility. And, generally this is all also sharing a lot of fascia with, you can see your hamstrings coming back here. The biceps femoris short head being really tight. Again, excessive knee valgus is going to cause this. We got to fix that pronation distortion syndrome, guys. It's the cause of like every freaking injury we've talked about today. What the? Again, we do not want this posture in our clients. We've got to fix the feet flatten, knees cave in thing. It's causing all of our problems. So that's a big one for runner's knee. And the meniscus tears are just coming from like general instability of the knee. Your menisci are these two little C-shaped pieces of connective tissue that sit on the top of your tibia. They are meant to increase the how much like, of a concave nature your knee has, so that your femur doesn't ever slide off the top of your tibia. And there's kind of different versions. This is what's called a bucket handle tear. Where you'll see that version sometimes. There you'll see it like that, where it looks like you can just thread your hand into it. You'll see radial tears. There's a lot of different versions out there, but basically if we tear that meniscus, that's going to create instability in the knee. How did it get caused? Well, by already having instability in the knee. So again, doing balance exercises is going to be really helpful for fixing meniscus tears, unless if it's really severe, your client's gonna need surgery at the end of the day. They need to go in there and fix that. Injury prevention, we need to fix it, right? Well, improper range of motion and stabilization of the knee, but also of the ankle and also of the hip, because your hip is above the knee, your ankle's below the knee. Your knee is trapped between these two structures. So you need hip stability, you need ankle stability, and you need knee stability. We have to do that, right? So lots of balance exercises, proper range of motion is going to be huge. Weight-bearing exercises where we're strengthening the hips, the quads, and we're focusing on stability and working in all planes of motion. Again, generally people are pretty good at moving through the sagittal plane, but they don't do very much frontal or transverse plane, right? So learning how to twist, learning how to, side shuffle, those are very functional movement patterns. So stabilization and balance exercises and strength of the lumbopelvic hip complex, which is what we're about to get to here. Any questions on knee stuff? Knee questions? Any Knights of Knee out there? No? Okay. So let's look at low back injuries. Low back injuries. This one's personal to me because it runs in my family. So low back injuries. This is general acute low. Okay. So lateral ankle sprains are the most common like sports related injury. Low back pain affects 80% of humans at some point in their life. So that is definitely the most common just type of chronic pain that people will deal with. There's a lot of different versions of back pain out there. There are disc injuries, which are really common. Those are slips, tears, herniations, whatever you want to call it. They're all, there's not really a difference. Actually, I'd be kind of curious because Lorianne, you've worked in the nursing field. I'd be curious if your take on this, how often doctors like to separate terminology between like, that's a slipped disc, that's a herniated disc, that's a torn disc in the back. They're all the same thing, really, at the end of the day. Sometimes you'll hear like people will use like slipped to mean like, okay, your disc move, it's bulging, but it's not fully herniated. It's like, okay, well, it's causing the same type of pain, like it's like the difference between like people will say like pre-hypertensive versus hypertensive or pre-diabetic. It's like you're either diabetic or you're not. It's either causing you problems or you're on the road to getting problems. Either way, we need to work on your sugar. I don't know. That's my controversial hot take for the day. Sometimes we have too much terminology. It's like, well, I'm only pre-diabetic. I'm still going to go, drink a gallon of sweet tea. And it's like, all right. So let's look at a herniated disc. Okay. So you've got all of your spinal discs, right? And yeah, okay. Oh my God, there we go. Look at this. I'm getting the terminology. Bulging disc, herniated disc, degenerative disc. Yeah, there's some slight differences in what's causing it, but they're all causing the same type of pain, right? So this is what your discs look like from the top down. They are this very soft connective tissue in between each of the individual vertebrae. And there is this, we call it nuclear material, nuclear pulposus, which is this sort of wet, squishy material here. And there's this membrane lining around the outside. If that membrane gets torn, that's a herniation. Okay, so herniation in the medical world means to tear the lining of something and something else is leaking out. My advice to you, no worries. My advice to you is to never Google the word herniated or hernia. It is some disturbing images. But if you tear the lining of something and something else starts leaking out, you've herniated it. Okay, so if you tear the lining of this outer membrane and this pulposus material starts leaking out, there's your spinal column, right? This is your spinal column, and there's all your peripheral nerves that are branching out from that. So now you've pinched your peripheral nerve between this soft, squishy material and hard bone, which is why the pain is pretty inconsistent. It's like maybe that squishy material isn't pushing too hard right now. So you have a good no back pain day, but then other days are really bad where this material is really pushing on those nerves. You push on nerves, what happens? They create signals. It creates pain, right? So this can happen in the neck, but generally, I mean, yeah, that's actually pretty common. But I'd say the most common is going to be in this area right down here, your lumbar spine. Usually it's the L4, L5. So generally we will see herniations. Yeah, L4, L5, those are your two bottom vertebrae here before, they kind of attach to your sacrum. And again, that makes sense too, because this is a very stable, your sacrum is a big hard bone that's very stable. These guys got to deal with like all this force. Newton's first law, right? Every action has an equal opposite reaction. Well, this friggin' thing's pushing pretty hard and these little discs have to deal with it. And then also they are stacking the rest of your entire spine on top. So L4, L5, they got a hard job in this world. And so oftentimes we'll see herniations in there. So that's a really big one. Slipped discs, you know, tears, whatever. Muscle strains just in the low back, that will happen. Sometimes you'll just get like a strained muscle in the back. You've got all of these little, like, you remember your multifidus is not one muscle. We kind of call it the multifidus as if it is one muscle. And we kind of draw it here. You can see it's like this big line. But really what it is it's like a grouping of all these fibers that are there to like hold all of your discs in place, right? And create, like, you know, stability and extension and rotation and stuff. Well, you know, you pull any of those, you're going to get like a muscle spasm, right? It's going to freak out. It's going to start wrenching down really hard. There we go. That's a great picture. You can see, like, look at all these little tiny individual little fibers there, right? And so, yeah, like that's going to create, you know, a strain and, you know, a spasm. And then there's also SI joint pain, or sacroiliac dysfunction. So your sacrum's at the very bottom here, right? That's this little triangle shaped bone that holds your two pelvic bones together. Well, if we get dysfunction in that SI joint, it can cause, because like this is holding the two sides of your pelvis together, right? And it's meant to be able to do a little bit of rotation like this. It's meant to do a little bit of elevation and depression like that, a little forward, backward action, but very little, very, very little. This is not like a lot of other joints, right? Like we got these synovial joints that are really like fully movable. Well, this is only supposed to be semi-movable. And so like when you have too much mobility in this, it causes aches and pains. Sacroiliac dysfunction can be really brutal. What you'll often see is it'll cause like a tilting like this, right? Now we're seeing a scoliosis, right? Scoliosis is just curvature in the spine. And so this person is scoliosing, right? And so, you know, maybe it's because the QL muscle, your quadratus lumborum, is maybe too strong on one side, right? So this QL is pulling too hard, and maybe this one's too weak. And so that's causing this lateral shift. If you keep your wallet in your back pocket and you sit on it every day, you are tightening up one QL and you are loosening the other one, because you are laterally shifting your pelvis. If you are tucking one leg under the other, which I have a really bad habit of doing, you are tightening up one of your QLs. If you are doing side bends, I know I've been ranting on this a lot lately. I feel like it keeps coming up. I hate that exercise. I hate side crunches. I do not like any of those because you are just creating mobility problems. And eventually, I believe, it's going to lead to SI joint pain. So that's a lot of them, right? So disc injuries, excessive motion or compression in one of the discs that causes a herniation, and then that material starts poking your nerves. That's the problem, right? That's the mechanism for how it occurs. How the heck do we freaking fix it? Well, we need to reduce the compression and reduce the torque. We need proper extensibility. We need proper mobility of the spine. And we also need proper stability. So many people will go like, oh, I have a weak core, and then they'll go straight to doing lots of crunches, right? And it's like, well, now you're focusing on strengthening the core that moves your spine, but what are you doing to strengthen the core that stabilizes your spine? What are you doing to teach your spine how to hold itself in place properly? That's what we need. We need you to hold your discs down. We need you to hold them in a proper range of motion. And that's not what we're getting with like lots of crunches, lots of freaking side bends, you know, things like that. So we need to focus that local stabilization system before we strengthen that global stabilization system. I like sit-ups. I like crunches. I think they're great exercises. But if you start with that instead of starting with planks and, you know, building a foundation first, you're focusing on learning how to move before you can learn how to like stand. You're trying to walk before you can stand, you know? We'll also see like, you know, muscle strains and ligaments, right? This often comes from like alterations in posture where it's, you know, you have an anterior pelvic tilt or a posterior pelvic tilt, anterior being the more common of them. right? So you'll see a client whose hips are dropping, you know, very excessively, right? Now, for the record, there should be a slight pelvic tilt, you know. It should have like a little bit of a forward, you know, lean, but that angle shouldn't be super intense, right? Because what's going to happen there is, well, then, you know, all of your weight's going forward this way. So then you'll round your back to send more of your, you know, upper posture backwards so that you can like keep, you know, you'll see this like forward head, rounded shoulders, anterior tilt, right? That's the upper crossed and lower crossed syndromes that we've talked so much about. So this is what we're looking for in a neutral spine. This is an anterior tilt. She's still got like pretty good upper body here, but generally that will also cause, again, shoulder rounding and a forward head posture. So not awesome, right? We need to focus on limiting this excessive motion and stabilizing it, right? Learning how to hold the spine down. So proper posture needs to be maintained, and it'll keep those muscle strains from happening. And then again, we are seeing SI, just joint dysfunction. Again, that's too much mobility in one half of the pelvis, right? And so we're seeing this lateral tilting. Or sometimes you'll see like rotational movements too. Sometimes you'll see, you know, one pelvis will rotate forward and the other one will be kind of locked in place, or maybe rotate backwards. And so you'll see people with like a twist in their spine as well. That's not great. So we need to focus on stability here. So how do we focus on stability? Well, we are first going to mobilize the areas that are tight. So when we do have like excessive motion on one side, we have limited motion on the other. So if somebody's got an anterior tilt, right, that means the hip flexors are really tight, you know, in this section, and the low back is really tight, right? We see excessive tightness in the erector spinae, so we need to mobilize that. We see excessive tightness in the hip flexors, we need to mobilize that. So we will focus on creating mobility. We'll have flexibility for our overactive muscles, and then we'll focus on strengthening our underactive muscles by focusing on developing stability, right? We're going to do exercises like planks. We're going to do exercises like that McGill Big Three that I always love talking about. That's the best 3 exercises for creating stability. A little bit of stability on the front here, a little bit of stability along the side, a little bit of stability in the back. And then again, I do love planks. I love prone cobras. I probably wouldn't do a prone cobra with an anterior pelvic tilt because that's, you're seeing extension here. We don't need more extension in somebody who already has some, but planks would be great. You know, this is a freaking fantastic exercise for focusing on stability. Bird dogs are really good. That's a really good one for focusing on stability, right? And then one of the other things that we're going to talk about, and you can see it here, is paying attention to that draw in maneuver, right? So pulling your belly button toward your spine is a great way to activate those local stabilizers. So always instructing our clients to keep their belly button pulled towards their spine. Engaging that is a great way to activate those stabilizers. Rather than only focusing on the bracing. We like bracing and we like the draw in maneuver, but bracing activates your global stabilization system, which again, those are your crunchers. The draw in maneuver, pulling your belly button back, that activates your local stabilization system, which are the ones that hold your spine in place. So tell your clients, pull their belly button towards your spine all the time, you know, just pull it in. Yeah. Question.
You said bracing activates the global
stabilization, not the global movement system, which is like your glutes and stuff. Like, you know, the global movement is like your quads, your hamstrings and stuff that like really moves you around. That's your global movement system. But the global stabilization system, those are like your outer abs, right? Your 6-pack, your erector spinae, right? It's the outer ab muscles that are there, and they do create stability. It's the global, you know, stabilization system, but it does often also move the spine. They're muscles that are associated with stabilizing and moving. The local stabilization is just about stabilizing. That's where we need to put our priority. So drawing in is for local stabilization, holds everything in place. Bracing is great, and I love bracing, and you should always brace as well. But that will also strengthen, like, you know, your crunchers. Does that make sense?
Yeah, thank you very much.
Yeah, no problem. There was a great picture I saw one time and I've never seen it again. Global, local stabilization, global stabilization. There's a great picture that was just like, it was from the top down, and it was like a circle, and it was like you'd see the inner ring, and that's your local stabilization system, and then you would see the outer ring, and that's your global stabilization. I've never found it again. I mean, kinda. But I don't even think that was exercising. It said something about soil. But it was a top-down picture. And I really wish I could find that picture again. Because Lord knows I can't draw it. All right. Lastly, we got friggin' shoulder pain. Shoulder pain's a big one. I like how they talk about money on this one, because shoulders are they're very expensive to fix because it's so complicated to get in there. But $39 billion a year, good Lord. Occurs about 20% of the population, the most common of which is just going to be shoulder impingement, but I'd say the most severe of which is just going to be like a shoulder dislocation or a rotator cuff tear. So shoulder impingement. I like the word impingement. I don't know the root of it or anything, but it sounds like impingement, like you are being pinched, which is exactly what's happening. So shoulder impingement is basically where the soft materials in your shoulder are being pinched. They should be able to move. There should be range of motion here. But unfortunately, there's a lot of hard tissue, right? You got like this little bit of bursa here, right? It's this little fluid-filled sac that's there to kind of act as like a buffer. Well, this soft material can easily move. Well, if you pinch it with this hard material, and you're going to have problems. You're going to have a grinding, you're going to have a clicking in your shoulder. I'm sure most of us, if we move just the right way, can feel kind of a click in our shoulder when we move, right? That clicking is a sign of impingement. Maybe it's not causing you too many problems now, but it could be a sign. It's like, hey man, maybe let's work on some mobility, get those shoulders pulled back. This is why when you're doing things like lateral raises, guys, in the gym, you need to always pull your shoulders back and stabilize your scapula before doing that movement. I will literally, if I don't, I have to be very specific about myself, because I know that I will round forward during my lateral raises or whatever. I always have to be like 1, 2, 3. Like, pull the shoulder blades back, drop them down, tighten the core. And once I do that, no clicking. And if I'm lazy about it and I don't go 1, 2, 3 in my brain, like literally I hear it in my head. I go, 1, 1, 1. Like if I don't do that, I will click, 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 click. So overhead motions that are repetitive, poor posture that is obviously repetitive, working on the computer, very repetitive. That repetitive stuff causes impingement. And then shoulder instability, that's another one. Poorly, you'll get too much mobility this way, not enough mobility this way, moving in a way that you are not supposed to move. Not supposed to move. That will cause shoulder instability, right? We'll see weak muscles in one direction and strong muscles in the other. Oftentimes, guys, we're really good at internal rotation and we are not so good at external rotation. You can even see in the difference between me. Like when I play Frisbee, I'm right-handed, so I throw with my right. And so if you look at the difference here, watch my hands. I'm going to go here, and if I rotate back, right, look at how much further I can rotate back with my right hand compared to my left. That's a huge difference between my right and my left sides. I've got great mobility in my right because I spent a lot of time, stretching and then whipping a disc in a different direction. My left doesn't get that action. Luckily, because I'm right-handed, I use my right a lot, so I haven't really put too much stress on my left. And ever gotten like a left tear. But if my left ever had to try to keep up with my right, that stability might not be there. Hopefully it is. But like, maybe it's not, and this is where, again, this is why we need to do our face pull exercises. We need to do our external cable rotations. you know, we need to use corrective flexibility here. Stretch out the pec minor in particular, stretch out the pec major as well, stretch out the lats, right? We need mobility in these areas that get really tight. The big tight areas, generally your 2 pectoral muscles, major and minor, generally your lats, and then those internal rotators, that teres major, which is a big bad guy. You know, the infraspinatus, those muscles that, you know, pull you into this posture here. Whenever I'm talking about bad posture, my posture gets worse. Like, well, I'm just like describing it. And then eventually I'm like, looking at myself in the freaking video here. And I'm like, good God, you know, so we need corrective flexibility, right? We need proper extensibility in the shoulder complex. And we also need proper strengthening of the upper back. What do you need to strengthen? Well, you need to strengthen those external rotators and your upper back muscles that will pull you this way, right? We need those rhomboids. We need those middle trapezius muscles. We need those lower trapezius muscles, right? So scapular strength and stabilization, external rotation. Rotator cuff tears are very common, guys. I looked up shoulder impingement and look, here's a picture of a rotator cuff tear. You can see, right? This tendon just can't keep up. We have a problem, you know, this is wrapping around the back. Well, you've got muscles that are wrapping around the front, and the ones that wrap around the front have help from your freaking latissimus dorsi, which is massive. Right? Let's look at this lat muscle. It wraps around, it's huge, and then it goes underneath the armpit and grabs the front. That's not great. It grabs the front of your humerus there, right? Going under the arm, grabs the front. So it works to internally rotate you. It does this, right? There we go. There's a GIF. Grab in the front. So it goes like this. So is your teres major. So is your infraspinatus. Like all those infraspinatus, those muscles are working to round you forward. We need to work to pull us back. So we need to stretch out those lats. We need to stretch out those pecs. We need to strengthen those upper, you know, back muscles, the lower trapezius, the middle trapezius, right? These muscles that draw our shoulder blades back. That is going to be absolutely huge for preventing these type of injuries. These guys here, and your rhomboids in between the shoulder blades, right? So pulling back this way. And then external rotators as well. You know, scarecrow stretch is huge. Scarecrow stretch is a great way to stretch out those GIF. Nope. Stretch out those internal rotators. You know what? Here's the scarecrow. We'll do this one. So I know where she's going with this. This is a really good one because like you're getting the scarecrow action while you're also getting like a little bit of core. But yeah, basically see how she went into a position like this and then she lifted her palms away from the ground, right? She pulled them back like this. And then also she's doing her head. That's just a little bit, she's getting like a little deep cervical action there. In addition, you know, a little bit of like head pull. Honestly, just laying down and just lifting your palms up. That's big, you know? So, or like a wall angels is sometimes what you'll hear, wall angles. Oh, actually, it came up, even though I spelled it wrong. So wall angels are another really good one. Put yourself into this position here and learn how to press your arms up without your elbows or wrists leaving the wall. So this action here, really, really good for creating that shoulder mobility. So if you get stuck at the desk all day, right, and you find that your arms want to pull forward like that, you're going to focus on keep the elbow, keep the wrist, contact with the wall. You don't need to do that lateral motion, and just push them up and down, right? And just go as far as you can. Notice how she's not going all the way up, but if you eventually can get all the way up, that's great. That's what we want. And those are some just general injuries. You guys don't have to have all this memorized. That would be crazy, right? We moved through a very large list. But this is actually kind of what Mo's corrective exercise class will look like, except that you'll get a single day dedicated to each of these things instead of like 10 minutes out of, you know, a little PowerPoint. So I don't expect you guys to have all these memorized. You'll have a couple questions that are kind of related to them. Honestly, guys, just remember, how do you, like, what was the answer to most of these injuries? Stability and mobilization. Proper mobility in our overactive stuff, proper stability in our underactive stuff. It's the answer every time, you know? But I do think there's going to be like a question. Let me see. I think there is a question in here that will say like, what's an example of a strengthening exercise for like somebody who has like foot problems? Oop, that's my notes. Hush. Dad, you know better. Where is it? The one, yeah, this one here. How do you strengthen the intrinsic muscles? Every friggin' student I know who sees that, when they see intrinsic muscles, they immediately go to your intrinsic core stabilizers. It does say of the foot. So what did I talk about earlier? Towel stuff, right? Towel pickup. So I'm giving you that one. I'm giving you a hint on that one. Pretty well, more than a hint. But towel pickups, that's how you strengthen the foot. That's the only one that's going to be like a straight up which exercise is best question. That's the hardest question on that homework. And that's it, guys. You guys got through the whole sports book. How you guys feeling?
Feeling good.
Awesome. There is one chapter, by the way. There's one chapter we're not covering in this course, the nutrition chapter, because we literally have the nutrition mod coming up in like, we're starting in a couple days. So that one we skip. But there is one final at the end there. It's like nutrition for athletes. Lorianne, how you feeling?
I'm okay.
Oh.
I'm definitely got a review.
Well, it feels like a lot today because it's like injury, fix it, injury, fix it. Like I said, I don't expect you to you know how to fix all these problems. That's Mo's job. My job is to be like, this stuff exists. You're gonna see it in a couple months, you know,
Okay.
or in Galen's case, a couple days. All right, guys. I'll see you guys tomorrow in person.
And you email or text the address and everything?
Very much so. Yeah, it's going to be at a park. And it has a parking lot and stuff that we all meet up at. We'll meet in the parking lot before we head over to the field. It's going to be real sunny tomorrow, guys. I will bring some sunscreen, but bring sunscreen, bring water. Everybody, it's going to be hot. So you don't necessarily have to do all the sprinting in the world, but you can. It'll be really fun. But yeah, please keep yourself safe. Bring some water, guys.
Okay.
All right.
Thank you.
See you later, everybody.
I'm all caught up on the homework.
Love that.
Thank you so much for your patience. Okay. Good night.
Yeah.